next assessment that we're going to move on to is the FSS ICU. And who's performed the FSS ICU? Yeah. So this is a outcome measure that measures 5 functional tasks: rolling, transfer from supine in bed to sitting at the edge of the bed, sitting edge of bed, transferring from sitting to standing, and then walking. So the hardest thing with this assessment is the grading of assistance level. In your CRF form, it like really breaks it down in regards to whether the patient needed supervision or cueing or needed an object to assist with the task, and then whether the patient needed min, mod, max, or was completely dependent to perform the task. So we're going to go over kind of what all of those assistance levels look like, and Bahi's going to be the patient for that. Rolling, I would ask him to roll into his side and see if he can perform it first without any assistance or trying to reach for the bed rail. So Bahi, can you roll into your side? So that would be considered independent. He didn't need any supervision, he didn't need any cueing, he didn't grab the bed rail.
Do you instruct him not to? Because sometimes I think it's just like, and they just do, even if they don't need to, they reach for it.
Yeah.
So do you specifically ask him?
I say try to roll into your side without reaching for the bed rail or needing my assistance. So then the next thing you would try to see if they could not roll without actually grabbing the bed rail is, okay, now try to roll and reach for the bed rail. And so go ahead. Yep, go and roll into your side. So with that one, he didn't need any actual cueing to like coordinate the task, but he needed that bed rail to kind of bring his trunk over. So that would be when you would mark needed like an object to assist with that.
Is the bed usually flat though?
Yeah.
Okay.
Yeah. So with some of the patients in the ICU, they might have head of bed restrictions of like 30 degrees.
Okay.
But you could probably lay them flat as long as you check with a nurse or the provider. And then you could do the task with the head of the bed flat. But if you're actually using it for an assistance level, then you would have to actually mark it as the patient needed that assistance.
So for the FSS ICU, there's no standardized instruction as for the 6-minute walk?
No, there's no like formal standardized instruction. Alright. I'll bring his head down actually. So say for instance he needed some cueing just to like coordinate the movement, but he could actually still physically do the task without me physically assisting him. So Bahi, I want you to bend your right knee, and I want you to reach your right arm over and reach for the bed rail and pull yourself onto your side. So that would be considered needing cueing to perform the task, so you would mark that box as well on the CRF form. We're going to go ahead and start with min assist, and then we'll do max assist. Those are a little bit easier to demonstrate, and then we'll do mod assist. So with min assist, he's at least doing 75% of the work. So I'm only giving him like 25, up to 25% of assistance. All right, Bahi, I'm going to have you bend your right knee. Reach over. So just a little bit of guidance with my hands. I'm not really assisting too much with that. Alright, so now we're going to do max assist. So with this level of assistance, he's going to need a lot more help to get onto his side. So I'm probably going to be bringing his leg up for him, bringing his arm onto his stomach. So I'm helping a lot more with that. And so for completely dependent, I would literally be doing everything. I would probably even cross his leg like this, bring his arm over, and he literally would not be helping me at all. It would be all me doing the work, okay? So with mod assist though, you have a little bit more of a bandwidth of assistance level between 26 and about 74% of him doing the actual work of the task. So we'll try to demonstrate about 50%, him doing 50% of the work.
And Stephanie taught this in this specific order. Moderate assist is anything that's not minimum and not maximum.
Yeah.
Right?
It's just easier.
Yeah, because it's hard to define what moderate is, so it's just the not minimum, not maximum.
Yeah. Alright, so again, reach. Sorry, he was helping a little bit more, pushing through the leg, reaching with the arm on that one. Alright, so with reclined in bed to sitting edge of bed, that would be the next task that you would assess. You can either do it from this position, or you can go straight from like rolling into sitting. So we'll go ahead and have him roll on this side again. Alright, so if he needed mid assist to come up into sitting, you would probably be kind of helping guide his legs off the edge of the bed, and just a little bit of kind of contact on his shoulder to help guide his trunk into sitting. And if you needed max assist, you're gonna really have to get into a position to really help him a lot more. You're probably gonna be the one bringing his legs off the edge of the bed. I'd probably even bring the head of the bed up because he's already lost that point. He's already needing that much assistance. And then you're gonna get into a good position. He's a good max assist patient. Alright. And then if he's able to do more of the work and maybe is needing just assistance from his hands, he's going to roll into his side again, roll into your side, and bring your legs off the edge of the bed. And then go ahead and push yourself into standing or sitting. So that would be considered using an object to assist into sitting. And then again, if you needed cues to kind of coordinate that movement, you would say he needed cues or supervision. Alright, so once you get him into sitting, I would have him scoot forward because you really want both feet on the floor to assess for sitting. I would first see if he can just sit there with his hands on his lap, and if he can do that and he looks like safe, like he's not going to fall over any second, I would consider that independent. However, if he was kind of like doing this maneuver here and I thought he was going to like fall over, I would consider that supervision. Like I wouldn't just like walk away and leave him there, sitting at the edge of the bed. If he needed to use his hands to kind of support on the edge of the bed, I would consider that using an object. And again, the CERU form really breaks this down. You literally check a box if you see that he needs an object, you check a box if you see that he needs supervision. If he had needed like mod or max assist to get into this position, he's probably going to need about mod assist to min assist to maintain this position. So I would be here kind of help holding him up. If he needed max assist to maintain the position, I'm probably doing this here with the bed a little bit higher to kind of help him maintain that position. Okay. Any questions with assistance level?
It's more about the transition from when you get from sideline to sitting, and then if you're going to be testing balance, do you have any standardization for how
long?
Well, not for how long, but like when you said I'd ask them to scoot forward, let's say they're in that mod max assist area, how are you doing anything with the assistance from the transition to sort of sitting without feet on the floor to the position of testing?
I try to get the patient to the most optimal position that will allow them to like maintain their balance. So
we're setting them up for success.
Yeah, you want to set them up for success. You don't want his hips to be like way back in the bed and his feet kind of like dangling from the floor. I mean, who sits like that? So you would want to try to use like either the chuck or the pad underneath him to really help scoot him forward, even if he is mod assist. Because even then, they could be a min assist for sitting, but you might not be able to recognize that if you don't have him in the best position to facilitate that. Okay. And I know another question that's frequently come up is, does it matter like the duration of sitting? So say he starts out like min assist, but then like fatigues and becomes mod assist. It's really the percentage of like the time that you had him sitting up on the edge of the bed, like what is the average assistance level that he needed for that duration of time? Does that make sense? We're going to move on to the sit to stand task. Okay. So usually with sit to stand, I'm gonna first see if he can do it by himself without me assisting. So go ahead and stand up. So he used his hands just normally there, but I'd first see if he could stand up without using his hands. Perfect. Go ahead and sit back down. And then if he needed to use his hands to push up, or he had one hand on a walker and one hand on the bed, that would be considered using an object to stand up, okay? If even then he was not able to stand up with like cueing, with like the use of an object to help stand him up, with elevating the bed a little bit, I would come in to see if he could try to stand with just a little bit of assistance, so that min assist, still with him doing about 75% of the work, and me helping just that little bit of about 25% of the work. So I would come in one arm, so it was about min assist, I was barely helping there. So then we're gonna demonstrate max assist for standing. So this is one where you're gonna have to come in and get into a good position yourself to protect yourself and your back. Usually with a max assist stand, one, I'm gonna go ahead and elevate the bed just to make my life easier. And usually gonna have your knees blocking their knees so they don't buckle. And some people like to do hands like on the lower back. I like to really go in for the glutes to facilitate hip extension. Everybody is different based on comfort level. So I'm gonna go in this like here. All right, on the count of 3, we're gonna stand, okay? 1, 2, 3, up. So he was a good max assist for that. All right, go ahead and sit back down. All right. And so you're definitely not gonna be walking after that transfer, unless you wanna drag them down the hallway. And then mod assist is obviously gonna be between that 26 to 74%. So a lot of wiggle room when it comes to mod assist. All right. And then dependent, you would not be doing any of the work. So I'm not gonna even demonstrate that. But does that make sense in regards to the bed mobility, the sit to stand? Okay.
Question, if the patient's pushing on his own knees, you would grade for assistance
Yeah.
needed?
Yep, because he's still using his arms to help with the standing up. Alright, so now we're gonna go over walking. Walking is based more on the distance that they walk first before you get to those assistance levels, okay? So I think it is outlined in your book there. And we score it different clinically, but on the CRF form, you literally tick a box if they walked less than 50 feet. If they walked between 51 and 149 feet, you'll tick a box. And then if they walk greater than 150 feet, you'll tick a box, okay? Does that make sense? Okay. And then obviously if they're using a rolling walker or if they're using a cane, if they're using an IV pole, like, and they're using it for balance or as like an assistance, I try first to see if they're actually like using that for balance or assistance by taking the pole away if I see that they're relying on it too much, and then I give it back to them and just grade that as an assistive device. Does that make sense? I know sometimes with IV poles it gets a little confusing. The other thing, if they need like cues for walking like in a straight, down the corridor, like if they're kind of weaving all over the place, I'll consider that verbal cues needed to kind of maintain their position with walking, as well as like supervision for safety. And then obviously, like if they walk greater than 150 feet, the scoring is going to be more based on like their assistance level. But the scoring on the CRF is pretty straightforward, so you don't have to worry too much about that. This is the only task where you can have 2 people assisting and they don't get penalized for that. All the other tasks, if you needed a second person, so if he needed 2 people to try to stand, I would actually have to grade him as a 0 because of that second person. And so I think the question last year came up, well, what if you need the second person because of like the difference in sizes between the assessor and the patient? You would still have to base it on the fact that 2 people are assisting with that task. Does that make sense? But with walking, you can base it on whether or not two people assisted with the test. So say you have a patient that's ataxic and you just need somebody on both sides for like balance purposes, you can still grade it based on their assistance level, okay? All right, any questions regards to the FSS ICU? So obviously if their mod or max assist is stand, you would tick the box that you did not perform the walking due to weakness.